Welcome everybody to the WPC webinar. This is a live session for people who are joining us at WPC to prepare for the meeting, but also for people who can't make the meeting and want to have access to our panel of experts who will be speaking. This session is supported by an unrestricted educational grant from Lundbeck LLC, and we're very grateful for our sponsors for this meeting. We have approximately 350 people registered for this webinar tonight. People who come from countries all around the world, especially US, Canada, Australia, Japan, and New Zealand. About half of the people listening tonight have got Parkinson's, and the other group are largely care partners and family members, but they're also carers from the professions. Now, we've got the topic tonight is the non-motor complications and treatment options for Parkinson's disease. And we've got three panelists with us. Tim Anderson, he's the Van der Veer Chair of Parkinson's and Movement Disorders from Christchurch, New Zealand. Jennifer Goldman, she's the Section Chief in Parkinson's Disease and Movement Disorders at the Shirley Ryan Ability Lab and Professor of the Department of Physical Medicine and Rehabilitation and Neurology at Northwest University in Chicago. And we have Shen-Yang Lim, who is the Professor of Movement Disorders at the University of Malaya in Kuala Lumpur, Malaysia. So we've got really three fine experts to talk with you tonight. Now, it's interesting that 200 years ago when James Parkinson described this disease, he actually said that the senses and intellect are uninjured. He thought of this as just a pure physical movement disorder, and that really dominated our thinking until recent years. Now, the people with Parkinson's have always told us that there's much more to Parkinson's than just that. And gradually we've realized that Parkinson's is the disorder that can affect most parts of the body. The reason for that is that we've learned that the pathology, the Lewy body of Parkinson's tends to spread through the brain, and they spread in a pattern that's different between each person. And depending upon how these Lewy bodies spread through the brain, it depends on which part of the brain is affected, and those particular parts of the brain can produce symptoms. Now, an important part of that is moving into the thinking part of the brain and behavioral part of the brain, and so there can be neurological, neuropsychological, and psychiatric complications of Parkinson's. And it can also move into the autonomic system or the automatic nervous system, the system that controls blood pressure and bowels and bladder and sweating. And most people with Parkinson's recognize that those systems are involved as well. And so living with Parkinson's means that you have to deal with all these other symptoms, not just the tremor and the movement disorder. And looking after Parkinson's, it's really important that clinicians and carers understand these other symptoms as well. And that's what this next hour is all about. We're going to be talking about these topics. Now, as an audience, you have the opportunity to interact with us, and I encourage you to look on the viewing page, and you can see that you can enter questions for us. And we're looking forward to getting your questions because that'll shape our discussion this afternoon or this evening, depending on which part of the world you're in. Now, we're going to start out by looking at the autonomic or automatic nervous system. And Shen and Tim will be talking about that. And I'm going to start out by getting Shen to talk to us all and describe some of the autonomic challenges that we've got with Parkinson's. Shen.
Thank you, Barry. Good morning. It's actually early morning here in Kuala Lumpur, Malaysia right now for us. So my talk will be on autonomic challenges in Parkinson's disease. As you've mentioned, autonomic dysfunction involve problems to do with the automatic systems in our body. And this can occur many years before a diagnosis of Parkinson's disease is made. And we now recognize that symptoms are prevalent even in patients with newly diagnosed, untreated PD. Symptoms of autonomic dysfunction can substantially impair quality of life, and some symptoms such as orthostatic hypotension, if persistent, which will be discussed by the next speaker, Tim, may also be a predictor of shorter survival. So recognition of these problems is important, and physicians should actively inquire about, investigate, and treat these issues, as you say, as an integral part of managing Parkinson's disease. Especially since symptomatic treatments now are frequently effective. Now, in this day and age of patients and caregivers being active partners in care delivery, I just wanted to share a handwritten note a patient brought into my clinic a couple of weeks ago. By way of brief background, this is a 65-year-old lady with Parkinson's, diagnosed 25 years previously, treated with deep brain stimulation or DBS about 6 years ago, and still independent for her mobility and personal care and able to do some housework. So she came in with this note with a list of problems. Number one, she's written here, urine problems, the urge to urinate frequently. Number two, excessive sweating. Number three, bloated abdomen. Number four, constipation. And number five, hallucinations. This is how she's, prioritized the difficulties that she currently faces. So in my lecture, I will give a broad overview of the autonomic problems that occur in PD. And topics covered will include gastroparesis. This is an impairment of stomach emptying, constipation, drooling, urinary dysfunction, particularly overactive bladder, sexual dysfunction, and thermoregulatory dysfunction, which an example of which is excessive sweating. I will review aspects of clinical presentation and discuss management strategies using a pragmatic and, whenever possible, an evidence-based approach in the following four major domains. So number one, looking at potential aggravating factors. Number two, lifestyle and non-pharmacological or non-drug treatment strategies. Number three, medication treatments, bearing in mind that drugs for autonomic problems may sometimes treat one symptom while potentially worsening another symptom at the same time. For example, anticholinergic medications for overactive bladder may aggravate constipation. And finally, number four, the effects of DBS, which is increasingly used. There are many developments that have taken place in recent years in terms of our understanding and research in this area. And I'm really looking forward to discussing these issues in more detail during this webinar and at the upcoming Congress. I'm also very excited that this is the first time actually that the WPC will be coming the Asia Pacific region to Kyoto, Japan. So thank you very much.
Thank you, Shen. There's going to be lots of questions for you, but what we'll do is we'll move on to Tim now and let him give an outline of what he wants to speak about, and then Jennifer, and then we'll come back to you. Tim, do you want to talk about some dizziness in particular?
Yeah, sure, Barry. Thank you. And actually, I'm from Christchurch, but I'm talking to you from sunny Sydney, the beautiful harbour of Sydney. So my brief is to talk about the dizzy patient, and the key thing I think to start with is to sort out, well, what's dizziness, and everyone's definition of dizziness, particularly patients' definition of dizziness, obviously varies. And so it's our role as doctors to try and probe what you mean as a patient by dizziness, and it's your job as a patient to try and be as explicit as you can to say what type of dizziness you have. And then it's a matter of whether we need to investigate the cause of that dizziness. Sometimes it's obvious. And then the key thing is going to be management of your dizziness. So dizziness means different things to different people. So for some people, it would be a sense of movement or spinning. We call that vertigo. For others, it would be a sense of lightheadedness, as if you're going to faint. And that's a very common symptom in people with Parkinson's. In others, they mean by the word dizziness, a sense of unsteadiness or loss of balance. And that might mean that that your postural reflexes are impaired. And for others, it just means a general sense of floating or wooziness or even heavy-headedness. And for some people, and many of my patients, they say, well, I feel dizzy. And you say, well, what do you mean by dizzy? Well, I just don't feel right. And well, can you describe it? Well, I can't really describe it. I just don't feel well. And so it's very important at the outset to try and tease out what the nature of that dizziness is. And as I've alluded to, it might be from the inner ear, completely unrelated to your Parkinson's. And in that instance, it might be that you wake up one day, turn over in bed, and you feel very dizzy. Well, that's not the sort of the low blood pressure dizziness that we encounter in many people with Parkinson's. That has its own treatment, of course. For other people, and most commonly, it's a drop in blood pressure on standing. We call that orthostatic hypotension. For other people, it might be that they've got poor circulation from other reasons, heart failure and so forth, causing inadequate blood flow to the brain. But for others, it may be that they're having side effects from medication causing dizziness. So we need to look at the other medications that patients might be on. For others, it may represent an underlying anxiety syndrome. And of course, anxiety is very common in people with Parkinson's, even before the motor symptoms present. And that may be associated with hyperventilation causing dizziness. It may be you have anemia, or you may have low blood sugar. So it's very important to sort out at the very outset what is the cause of the dizziness. And as we know from Shen-Yang, dizziness and orthostatic hypotension can occur before the actual motor symptoms. Dizziness is very common in Parkinson's. So in surveys that have been done, up to nearly half the respondents said they had some form of dizziness. And a significant proportion, about 10%, actually had symptoms of the inner ear type of dizziness, which needs its own form of treatment. So most causes of dizziness in people with Parkinson's is really due to low blood pressure, which we call hypotension. And it's a type of blood pressure in most people that when you stand up, you get lightheaded and dizzy. And that's then called symptomatic orthostatic hypotension. For others, the other second type is postprandial hypotension. That's low blood pressure after eating meals, which is due to pooling of the blood in the gut circulation, causing dizziness within an hour or two of eating. Now, in most people with Parkinson's, the orthostatic hypotension, the low blood pressure on standing, is called neurogenic orthostatic hypotension. That means that the nerve cells in the peripheral nervous system. So we used to think that Parkinson's was solely in the brain, but in people with Parkinson's, some of the nerves that go out to the blood vessels and the peripheries and the limbs and the rest of the body are affected. And that affects the adrenaline system, the noradrenaline system, and that's deficient. And so that results in a low blood pressure on standing. And we define orthostatic hypotension as more than a drop of 20 millimeters of mercury when you systolic when you stand, or more than 10 millimeters of mercury when you diastolic blood pressure. And if it's neurogenic, it means that when you stand up, when we all stand up, we may get a bit dizzy, but if you stand up and you can't raise your pulse rate in response to raise the blood pressure up to normal again, then that suggests you've got neurogenic hypotension. And that's really defined as an increase in pulse rate that's less than 15 beats per minute when you stand. So just to finish off really, what's the best treatment for dizziness on standing, neurogenic hypotension, orthostatic hypotension? The key thing really is to address the non-pharmacologic methods. In other words, what are the background drugs that you're taking? Are they antihypertensives that might aggravate low blood pressure on standing? Are there other reasons? Are you anemic? And so forth. And then one tries to address non-pharmacologic methods of controlling the low blood pressure on standing. So for example, one would increase your fluid status, look at the fluid status, have extra salt and water during the day, avoid alcohol and caffeine during the day, avoid very sugary drinks because they can reduce the blood pressure, and avoid high carbohydrate meals before bedtime. Any exercise, which is really important in Parkinson's, it's best to do it either seated or supine. So swimming is very good exercise for people who have low blood pressure on standing. Rowing or an exercycle, things that don't involve a completely upright posture. Other ways that you can improve your blood pressure, at least transiently, are to do muscle clenching exercises when standing. That's sort of clenching the buttocks or crossing your legs or standing on tiptoes and so forth. And the other key method is to reduce the amount of blood pooling in the lower extremities or even in the abdomen. And so that's been stockings or abdominal binders And a key thing is to raise the head of the bed up at night, so that there's so that there's some pulling in the legs when you lie down at night. So the other, if those measures aren't effective, then we're moving on to pharmacological measures of treating low blood pressure on standing. And there's only 2 drugs that are actually licensed by the FDA to increase blood pressure on standing, and that includes midodrine and doxydopa, and they raise blood pressure up by increasing the adrenaline system. And the other way of treating is with alpha-fluorocortisone, which expands the blood volume. And then there's a number of other measures which one can use, which from small trials have shown some benefit, and I'll talk about that more at the meeting. So I think the key thing for patients and for doctors is to sort out the nature of the dizziness, to then, if it looks like it's orthostatic hypotension, neurogenic hypotension, take the lying and standing blood pressure. If there's a significant fall on standing and without an increase in pulse rate, then it's neurogenic. Then address the non-pharmacological measures, as I've mentioned, and then move to drug treatment. But drug treatment is really the end of that management hierarchy. So I'll leave it there for the moment, Barry, and take questions later.
Yeah, thanks, Tim. We're getting some great questions coming in from the website, and we'll address most of them later. But there's one here that's very specifically for you that we might do now. Could dizziness be an early indicator for Parkinson's? And if they've just got the dizziness, is it best to go to a neurologist, or is there another specialist that you'd advise?
Well, I think if you have dizziness and no other symptoms of Parkinson's, you're best to see the family physician. Because as I mentioned at the start, there's a whole lot of different causes of dizziness other than Parkinson's. Sure, yes, you can have dizziness before the motor symptoms develop, but usually there are other factors as well. So isolated dizziness without, say, constipation, anxiety, some of the other premotor symptoms, isolated dizziness on its own would be unusual as the initial presentation, but in combination with the others, not uncommon.
Okay, thank you. We'll come back to dizziness, but first I want to give Jennifer a chance to introduce her topic, psychosis, and Jennifer, over to you.
Good evening, everyone. It is evening time in Chicago, so welcome, and so happy all of you could join us today, or in the morning or in the evening. So my talk in Kyoto is going to focus on Parkinson's disease psychosis, and specifically has the treatment paradigm shifted and changed over the years. Tonight, I'll actually cover a hybrid of 2 neuropsychiatric symptoms, psychosis and cognitive impairment and dementia. The piece on cognition and cognitive impairment in Kyoto will be covered by a colleague of mine, Dr. Dan Weintraub, a psychiatrist at the University of Pennsylvania in the United States. And we're very excited to be able to talk about these issues because indeed our landscape of understanding, recognizing, and even treating some of these neuropsychiatric symptoms has indeed shifted over the years, certainly from the time from James Parkinson to current. And we'll delve into some of these changes, some of our advances in understanding the issues, and even new treatments that are currently under study. We continue to strive and make gains in these areas. But I think first and foremost, I did want to say a few words about us talking particularly about neuropsychiatric issues in Parkinson's, and in particular psychosis, cognitive impairment, and dementia, because these can often be very scary or frightening or fearful topics. And I think it also should be recognized that while we are talking about them tonight or this morning, that not everyone with Parkinson's experiences these symptoms. So I may talk about some things that some people have experienced. I may talk about some things that some people may experience as part of their Parkinson's journey, but not that everyone will develop. But I do think it's really important, and one of the reasons I think it's so wonderful to have this type of webinar and session focused on non-motor and neuropsychiatric symptoms is in order to be proactive and to reduce the fear or stigma that's associated with these features, education is one tool. And I know not everyone always wants to hear every piece of information, and people can be selective about what they pick and choose, but learning about this, talking about it, particularly about mental health topics, which can have a lot of stigma, is one way to reduce the fear and be proactive and potentially prevent some of these symptoms from happening. So I encourage people to have open conversations about these topics, like in this educational forum, opportunity to ask questions, talk about it with your family, talk about it with your healthcare provider, and all the people who are on your medical team. So I did want to spend just a moment to talk a little bit about some definitions to make sure we're speaking a common language, no matter where in the world we are today. And then hopefully we'll have time to talk about, some of the treatments that are underway or even on the horizon. But psychosis, just as a terminology, is really a broad spectrum of clinical features. So it formulates an umbrella term that ranges from illusions, which can be misperceptions, could be visual or auditory, but there's something that's there in the environment that is perceived as something else. So like looking at 4 legs on a chair, but it looks like a dog. So a misperception. Psychosis also includes hallucinations, which can range in quite a number of features and also severity, from feeling like there is a sense of presence or a shadow or something on someone's peripheral vision, to formed examples of little children or little animals, or even some frightening and more distorted figures that can appear. Visual hallucinations tend to be the most common that we see in Parkinson's, but we can hear reports of noises or music or sounds that aren't present, as well as smells or feelings or tactile sensations. We can also see under the umbrella of psychosis something called delusions, which are thoughts that or beliefs someone has that is not true or not truly occurring. And sometimes these can involve suspiciousness, paranoia, thinking infidelity or jealousy. And of course, there can be a very wide range of symptoms, from being mild or intermittent to sometimes more intense and scary. These symptoms under psychosis can also tie in to other non-motor neuropsychiatric features, which I hope we'll have the opportunity to talk about, whether they be cognition or sleep changes or different types of medicines, like even bladder medicines that we talked about with Sheng, sometimes can contribute to psychosis. I just wanted to spend a word on the cognitive symptoms and just a few definitions to make sure we're all on the same page when we think about these things. So we talk a bit about cognitive impairment, and this can happen across a wide spectrum of Parkinson's, from even early stages with mild slowing of processing, slowing of thinking. It's kind of like our mental equivalent of bradykinesia, or slowed movements. We can also see cognitive changes that are mild, and a term that's evolved in our world is something called mild cognitive impairment, or MCI. And this means people may experience some milder cognitive changes, but they don't generally impact someone's day-to-day function. They can evolve into more intense or severe cognitive changes over time, but as we're learning, not everyone with mild cognitive impairment does develop a dementia syndrome. And so just to define dementia, because this is a question that I often get asked, is we think of dementia as something that occurs gradually, so not happening overnight, but over a course of years, where people have changes in more than one area of their cognitive functions. And that is severe or significant enough that it affects someone's everyday life, their work, their hobbies, driving, and so forth. We also know that dementia, which can occur in Parkinson's, particularly later in its course, is not the same as Alzheimer's. And it does not necessarily involve only memory function. So we recognize that people may have trouble with their attention or concentration, something we called executive functioning, like planning and processing, organization, finding the right words, or even finding one's sense of direction. And I think just before I turn it back to my colleagues and audience, we are learning much more about why these symptoms occur in Parkinson's, how we might be able to halt them or prevent them, as well as how we can better treat them both with non-pharmacologic measures, such as cognitive therapies, physical exercise, as well as medications. Right now, there are 2 that are approved, one called Rivastigmine, at least in the United States, for Parkinson's dementia, and one called pimavanserin, which is approved for psychosis in Parkinson's. But there's a lot on the horizon as we look at these issues in Parkinson's.
Thank you, Jennifer. Boy, there's a lot in there, and I know we're getting some questions. And I want to come back to hallucinations in a little while, but I wonder if we could wind back to the very beginning of Parkinson's. And something that struck me that I was never really taught in medical school is how common anxiety is in early Parkinson's. And sometimes it's the very first symptoms looking back. A person was never anxious before, they became very anxious. And then within a year or so, they get a tremor or the Parkinson starts to develop. And could you talk a little bit about that and particularly move on to what people can do about that and the treatment?
Sure, and anxiety is a common problem, not only in the general population, but also in what we know in Parkinson's, with estimates, looking at wide variety of studies, estimates 40, 50, even higher percentage of people may at some point experience anxiety. And anxiety can mean a lot of different things to different people. It can include worrying, feeling nervous, feeling tense. It can have what we could sort of consider the mental symptoms associated with anxiety, but it can also have the physical manifestations, which Tim mentioned. So rapid heart rate, hyperventilation or fast breathing, sweating, even increased tremor. And from what we're learning, as Barry mentioned in the beginning of the program, with this notion of the development of Parkinson's, is that there may be changes in brain chemicals, such as norepinephrine or serotonin, even years before people have tremor or movement symptoms. And those brain chemicals are linked to neuropsychiatric symptoms, in particular anxiety and depression. And this may be why people may experience some of those symptoms even before they develop the movement symptoms. People can have anxiety in different situations as well, such as with walking or with tremor, being in public for different reasons. But I think one of the important pieces and take-home messages that anxiety can be very treatable, and understanding its context can help us as healthcare providers work with a person who has Parkinson's, devise the best strategies. Some of those might be working with a counselor or a psychologist, or even techniques to help reduce anxiety. It may involve non-pharmacologic measures like yoga or meditation. And then of course there are medicines that we can prescribe as healthcare providers that can lessen anxiety depending on when it's occurring.
I'm quite struck how sometimes levodopa, the Cinnamate or whatever, sometimes does a good job treating the anxiety.
Yes, and if I can just speak to that for a moment, I think one of the several unrecognized elements of Parkinson's, when people are on medication regimens to treat the motor symptoms, is this concept of non-motor fluctuations. So we very much think of motor fluctuations with medicines wearing off at the end of a dose, or extra involuntary movements like dyskinesias. But we don't always think or ask people about these non-motor fluctuations when their medicine might be wearing low. And one of those fluctuations actually can involve anxiety. People can develop symptoms that are reminiscent of panic attacks, even in their medication cycle. And so strategy for that is actually treating it in a way that we would for a motor fluctuation. So great.
Yeah. Thank you. Gosh, there's a lot here. We're getting some more questions, but I wanted to come back to Shen, actually. Shen, you were given a very big topic to talk about, and I was interested to your comment about your the person you're looking after bringing along a note with all these things. Can you share with our audience some tips on how best to prepare for the consultation, talking about the non-motor symptoms? What do you as a neurologist want to hear, and how is it best for the person to come along and tell you about that?
Thanks, Barry. I guess the first thing is to make sure, from our part as the treating physician or neurologist, is to make it such that the patient doesn't feel embarrassed to bring up these issues. And so, we would usually start our consultation by asking patients what kind of problems are you having recently, rather than specifically honing down on movement-related issues. For example, how's your tremor, or how's your walking lately? So that gives permission in a way for patients to come in and discuss all sorts of issues. And actually, for many patients with Parkinson's, these non-movement issues may be predominant. So, for example, in the list that I showed before, which was completely unprompted, the patient brought it in. 5 items, all 5 in the so-called non-motor symptom domain. Interestingly, 4 in the autonomic domain, and the 5th one is the occurrence of visual hallucinations. Now, some physicians will use certain questionnaires. So there are now some questionnaires which are widely used to probe the occurrence as well as the severity of these symptoms. So I know that some of my colleagues will routinely make available these questionnaires to be filled out by patients before they come in, sometimes in the waiting room, for example, and these can then be flagged when it's brought in for the consultation. I generally am a bit more laid back in my approach. As I said, I think we take an open, flexible approach to try and discuss and address the main problems that a patient is coming in with. I guess one of the difficulties I have in terms of using a broad sort of questionnaire with, for example, 30 questions on various non-motor symptoms is the difficulty we have, at least in I'm sure in many parts of the Asia Pacific and elsewhere as well, is of course that the limitation in consultation time. And it's not uncommon that my colleagues and I come to a clinic and we have a huge number of patients to see. And in reality as well, usually when we consult on a case, I think it's not possible to make too many changes all at once. So we have to try and prioritize in conjunction with the patient what are their most pressing problems. So I see that many patients will bring in a short list, and that's very helpful. So they have, in a way, prioritized their symptoms. Now, this, of course, assumes, and this is what I come back to, what I mentioned before, that the patient has some knowledge about the possible range of symptoms that can occur as part of their Parkinson's disease. 15 years ago, when, for example, this issue of impulse control disorders was not recognized to be part of PD, patients and physicians would not discuss this in the context of a consultation. So now that we have, educational sessions like this, materials on the internet which are easy for patients to access, I think patients and caregivers are much more knowledgeable, and so they are, when they come to the consultation, they're able to bring in complaints or symptoms, which are much more reflective, broader of their day-to-day experience and difficulties.
Yeah, thank you. I find the lists helpful. I have to say, I get very dismayed when the person has finished the consultation, they stand up and then they reach in their pocket and say, "Oh, I've got a list of things." So it's quite good to get that list out very early.
Right at the
Jen,
start, yeah.
yes, indeed. Jen, I want to change topic because I've got a question from the USA that quite a scientific one, asking about the on state and the off state with levodopa. So as the medication works and not works. And one of our questions is noted that there's some autonomic things that come to the surface during the off state and wants to understand that science a little bit better, and does that have any implications?
Yeah, so as Jennifer already mentioned before, many patients with Parkinson's in the course of their disease and treatment develop what are called motor fluctuations, as well as dyskinesia. So this is the situation where, whereas at the start of the illness, when a patient takes medication twice or 3 times a day, the effect is long-lasting. But for many, and this takes a number of years before they manifest, the effect of the medication becomes shorter. So, for example, a patient will come and say that, I take the medication, my condition improves significantly after about half or 1 hour, but the effect may last only 3 or 4 or 5 hours. And in this situation, in the so-called medication off state, patients will experience a recurrent or worsening of their movement symptoms. So, for example, slowing, tremors, stiffness. But in addition, a number of research studies, and we know this, of course, from clinical experience, because many patients report these symptoms. They experience what are called non-motor fluctuations as well. And there is a broad spectrum of possible non-motor fluctuations. Many of these occur in the medication off state, but some can also occur in the medication on state. I'll come to this shortly. So in the medication off state, as was mentioned by Jennifer, many patients can have a depressed mood, low mood. They can have panic attacks, anxiety. But in addition, autonomic symptoms may occur as well. So it is quite common to hear from patients who report having excessive sweating when they are off, or sometimes in the opposite condition when they are on and having, involuntary dyskinetic movements. Some patients will also report having difficulties with urination. So interestingly, although the effect of dopamine replacement medications on some of these autonomic functions like urination is very variable between patients. Some patients will say that when they are off, they are unable to urinate. So it's very clear now that these symptoms are not merely in response to or a reflection of having a worsening of motor symptoms. I think, when you asked about the pathophysiology, Barry, I think this is still something that is very, poorly understood. When I sort of embarked on my research career in Parkinson's disease, we looked at pain, fluctuating pain in patients with Parkinson's disease. And what was very interesting was that so after a dose of levodopa, we would examine the patients every half an hour for about 4 to 6 hours. And it was very interesting. One could see that there was frequently a worsening of mood and of even pain sensitivity coming on before we could detect any changes in their movements. So these are, I think, interrelated problems, but the pathophysiology is still it's still something that is not very well understood. In many patients, thankfully, there is response to dopamine replacement medications. So by trying to attenuate the off time and sometimes by reducing the dyskinesias, we can address some of these symptoms.
Yeah, thank you. That's a great answer. It's quite interesting, this business of as the levodopa fluctuates, it does more than change the physical performance. It changes the autonomic, but it also changes the psychological and psychiatric performance. And Jennifer, I want to turn to you for that. I don't know if you're watching the questions, but we've had a couple of questions now about as the levodopa goes up and down, what does it do to a person psychologically? And I wonder if I could get you to weave that into another answer, which is that there are degrees of what we call psychosis. So at the lower end is sort of a feeling that somebody else might be in the house, or every now and again seeing a cushion as a cat, and maybe that's not so harmful. But then you talked about some more frightening ones about paranoia and intense hallucinations. And I want you to talk to us a little bit about the effect that drugs have on these fluctuations. And if you've got somebody in clinic with you describing these things, at which point do you start to change the pills? You've got somebody here who's asked about amantadine, whether that should be changed. Can you address that for us?
Sure. These are really fantastic questions. So to just maybe tackle the first part on the fluctuations and some of the psychological aspects to tie that in, I think to Shen's point, these non-motor fluctuations are very much a piece, or can be very much a piece of Parkinson's, and the recognition on both ends from healthcare provider end and from the person with Parkinson's are very important. We've also seen fluctuations in what people say about their thinking when their medicines are working or wearing off. And that can go actually either way. So in my experience, I've had some people who say when their medicines are worn off or are trailing down, they feel a little bit foggier or less clear. With that said, on the flip side, I have had in my experience people who at the peak of their dose and when their medicines are working may feel a little change in their cognition or cloudy or fogginess. And this is where all of, I think, the pieces of our seminar session tie together, because sometimes that fogginess relates to low blood pressure, and low blood pressure can affect fatigue, it can affect people's thinking and so forth. So with that said, just to move into kind of the next part of the question on the broad spectrum of what we call psychosis. And psychosis really, as I said before, encompasses a lot of different things. A lot of people still will call these symptoms by illusions or hallucinations specifically, and we've kind of lumped them under one umbrella term. With that said, there is a spectrum, and as I said before, the most common feature that we see includes visual hallucinations. The delusions or misbeliefs or other aspects that I mentioned are much less common, affecting a much smaller percentage of people with Parkinson's. Sometimes occur a little bit more if someone's also having some cognitive trouble at that time. But I think we bring them up in conversation because it's important to have that recognition and education and awareness in case they might occur, and in case being proactive should they occur, that we know what to do and how to embark. So sometimes if people have illusions or misperceptions or shadows or even visual hallucinations, as physicians, we may monitor them. We may also want to investigate other reasons people may have these, which could be some of the medicines actually we use to treat Parkinson's, some of the dopaminergic medicines, levodopa, amantadine, dopamine agonists, and others. And it may be a matter of the dose, and we may have to adjust that. People may develop hallucinations from other medicines used for bladder function or pain or other reasons. And I think we always need to evaluate and continually reevaluate someone's medication regimen. So again, going back to having those lists and questions, having lists of medications in an appointment is really important. Sometimes we will need to reduce the medicines if hallucinations are bothersome or scary, or people are acting on them in some way that we need to actually intervene. Sometimes a trick like having a nightlight on or diverting someone's attention is just enough to make it go away. And then sometimes we need to take another step, whether that is looking at medicines to actively try to treat the hallucinations or psychosis. One that's approved by the FDA in the United States is pimavanserin. Others that have been studied in the literature include medications like clozapine or quetiapine. Cholinesterase inhibitors like donepezil and rivastigmine have also been studied. So sometimes we need to actually actively add something to the regimen. And this is where the balance between motor function and mental function comes into play. So we know we can't necessarily always reduce or take away some of the Parkinson's medicines because that might impact mobility, walking, a tremor, and so forth. But yet we need to balance it with treating the mental or thinking and hallucination component. And then just seeing some of the other questions, sometimes as neurologists, many of us or movement disorder specialists will handle the management of psychosis, but we often work hand in hand, or in some centers, this is managed by psychiatrists, sometimes geriatric psychiatrists, and other members of the team. So some of that depends on where people live in the world and different access to care.
Great answer. Yeah, thank you. And I just want to add a point just for the audience. If your loved one suddenly gets intensely confused or intensely hallucinate, that's often an infection. And so if somebody suddenly changes, it's important to get really prompt medical attention, because sometimes it could be something like a pneumonia, which is otherwise not obvious. Great answers. Yeah. One of the things today, isn't it, is how everybody's saying how different every other person with Parkinson's is. It's quite a striking feature of the disorder. Our movement disorder nurse just retired from my hospital after 20 years of just amazing service. And I was sitting with her at coffee and I said, what have you learned after 23 years, Lorraine? And she said, well, I've just learned that everyone's different. Tim, I want to move to you. I'm going to take you off your dizziness topic because you're also an expert in the early cognitive changes in Parkinson's. And we've got a couple of questions here about MCI. How does it manifest? And also a bit of questioning about brain gym and Sudoku. And I guess that broadly says, what can a person do about it to minimize the chance of going on to MCI and then the MCI going on to something more profound like dementia? Can you tackle that for us? Well, Tim, you're silent to me.
Yep, I think I'm loud now. Thank you.
Yeah, you are. Thank you.
Yeah, thanks, Barry. Yeah, MCI. So what are the presenting symptoms? And they vary, as you just mentioned. Everyone's different with Parkinson's, and the symptoms that people with MCI present with are different as well. But for the patient, it's really saying, I'm just not clearly, I'm getting a bit forgetful in particular. I'm just not making the right sort of, I struggle with making decisions, often a lack of decisiveness. And that really comes through from the carer, the spouse, says, well, he's just lost confidence and he's just not as decisive. And, I have to start making some of the decisions in the family about where we're going for holidays, planning ahead. He doesn't want to really socialize quite as much as he used to, isn't finding conversations in large groups of people easy with friends. Those are the sort of the subtle things that would trigger off to me that this person is struggling a bit with their wider cognitive reserves, and that I would then want to dig a little deeper and administer some cognitive assessment tests to really sort out whether this person has mild cognitive impairment. Now, you're right, we do some research on mild cognitive impairment, and there's certain criteria for diagnosis, which are not easy. They're based on statistics and on testing cognition, psychological tests. But people need to be aware that if you get a diagnosis of mild cognitive impairment, that does not mean that you're going to necessarily go on to dementia. And so we know that a significant proportion of people just stay as mild cognitive impairment. And actually in our research and others as well, we found that people who are in mild cognitive impairment in one particular day testing, and the next time we test them, maybe 6 months or a year later, they've gone back to normal cognition by the criteria. So it's a difficult concept of mild cognitive impairment, but I think people need to be aware that there's no inevitability that you're on the slippery slopes to dementia. But it is a sign that you should be trying to do something about it in the best way you can. We don't have any confirmed medications that will help prevent people getting worse with their cognition. So it's up to the patient. The person with Parkinson's do as much as they can. Actually, the most important thing is exercise. So physical exercise daily, and it's got to be some decent exercise. And if you can't run, then you can swim or you can do an exercise. There's always a form of exercise that you can enjoy, boxing and the like. So everyone needs to choose the exercise they enjoy, because that's the one they'll stick with. There's no point doing an exercise that you actually hate. I don't go to the gym because I hate going to the gym. I'd rather play tennis. So you've got to choose an exercise that you enjoy, that you'll stick with. Actually, the same applies to sort of brain teasers and so forth. We're having trouble in Parkinson's to prove that actually doing these sort of brain sort of exercises is actually efficacious in improving your wider cognition. So we know that if you do Sudoku, for example, you can become a really good Sudoku person, but we're struggling still to try and prove that will spill out into other aspects of your cognitive function. But we all think that probably would, but the science has still yet to prove it properly. But just like exercise is really important, it's key to keep up as much as you can reading and learning new things, in particular challenging the mind to learn new things. And also what we've begun to understand, particularly in the Alzheimer's world, for example, is that you need to keep up social contacts, and that socialization and keeping up with friends and so forth is important to preserve your cognition.
Thank you. Now we're entering the last few minutes of our webinar, and I'm just going to put the three panelists on notice. I'm going to ask you for one take-home message each that might change things for our audience, particularly our people with Parkinson's or their carers. So I just want to set your mind to that. Shen, but I'm going to make you multitask, because I also want you to talk to us a little bit about these things that people find so embarrassing, sweating and maybe dribbling.
Sorry, Barry, I didn't catch that. Sweating and?
Maybe drooling? Yeah.
Oh, drooling, okay. So yeah, I saw in the list of questions, someone's asked about sweating, excessive sweating. This is a very difficult issue. As I mentioned before, in some cases, it can be related to being in the medication off stage or having dyskinesias. And in that situation, we would try and treat to reduce the off time and dyskinesias. Sometimes that involves, adding a medication with a longer duration of effect. It could be taking levodopa more frequently or at a higher dose. In some patients, it could be, if the condition cannot be adequately controlled with medication adjustment, it might have to be so-called these device-aided therapies like DBS. And we know, for example, that after DBS, some patients with excessive sweat have a significant improvement in this, as well as in other non-motor fluctuations as well. Drooling is something that there are a number of treatments for. So we recognize now as well that it's not necessarily something that occurs only in the later stages of PD. So with some large studies recently, surveying patients even with early stages of Parkinson's, many of them report having pooling of saliva in the mouth, and sometimes that pooled saliva, due to reduced efficiency of swallowing, spills out, and that manifests as drooling. So there are a number of ways to try and address this. First of all, non-pharmacological measures. For example, some patients will find it helpful to have a hard candy in the mouth or some chewing gum, which stimulates the swallowing to occur. And in others where this treatment is not sufficient, we have a number of medications available. For example, from a randomized controlled trial, we know that glycopyrrolate can be effective, and this medication is quite widely available. This is a medication that reduces the production of saliva. There are some patients who will use drops of atropine under the tongue, so sublingually, with reasonable efficacy. And in some situations, we offer patients treatment with botulinum toxin injections into the salivary glands, into the parotid gland and or the submandibular gland, again, to try and reduce the production of saliva. Although, as I hinted at before, in Parkinson's, the primary problem is not actually an overproduction of saliva. It's actually a reduced efficiency of swallowing. And I think in the coming years, we will have hopefully treatments that will address this underlying problem, but we don't have this as yet.
Thank you. Do you get the speech language pathologist involved?
Yes.
Yeah. Okay. Now, we're in our last moments. Your take-home message.
Talking to me, Barry?
Okay, yep. Tim, and then we'll come back to Shen to let him gather his thoughts. Shen, Jennifer, then Tim, Jennifer, then Shen. Your take-home message.
Take-home message is, if you think you have dizziness, you tell your family physician to make sure they measure your blood pressure lying and standing, because in my experience, they only take it sitting. So that's my take-home message. You instruct your physician to take your blood pressure lying and then standing.
Okay. Jennifer.
Okay. Well, thank you for having us tonight in the morning. And I'm going to just say 2 take-home messages, if you don't mind. One, I think it's just really important to have conversations about these topics, I think, as we've illustrated in this webinar, and be open and candid and not be shy about talking about them amongst your family, friends, healthcare providers. And then I think one theme that's emerged, and also a take-home message, is that it really does take a team. It takes a team approach. It takes, particularly for psychosis and cognitive changes, an approach that expands even one's team beyond movement disorder specialist to include whether the nurse, social worker, neuropsychologist, psychiatrist, as well as even the allied health team to work on cognitive and physical strategies, whether that's speech language pathology, occupational therapy, and physical therapy. And hopefully I've gotten a lot of people on the team. There are probably other more team members out there, but it really does take a village.
Thank you. Shen, last words.
So I just want to say thank you to everyone for joining. My take-home message is, firstly, be an active partner, learn about these various symptoms that can occur, so that you have a common language that you can discuss with your treating physician and other healthcare professionals. And the second message, I'm taking a lesson from Jennifer, is if I can encourage everybody to try, if you can, to contribute back and participate in research. In the trials of autonomic problems in Parkinson's disease, it's amazing that the number of studies that have recruited only about 20 or 30 patients, which of course causes difficulties in interpretation of these studies. So if I can encourage everyone to try and give back and participate in research as well. Thank you very much.
Thank you. So it's my job to thank our presenters today. I've really enjoyed myself, and I'm sure everybody listening has as well. I want to thank you again, Lundbeck, for sponsoring this session. I've found it very valuable, and we really appreciate this educational grant they provided to provide this session. And then in a week or so's time, we'll be together again in Kyoto, and we're looking forward to meeting some of the audience in person and spreading this message about the complexity and the individual nature of Parkinson's. So thanks very much, everybody, and good night or good morning or wherever you are in the world, and we'll see you in Kyoto.